thank you all for joining us today. My name is Cherise. I'd like to introduce you to my colleague, Marianne Mertz, who's an RN. She's a patient services coordinator for the ALS Association Greater New York chapter, and she's also the nurse coordinator for the Rutgers Robert Wood Johnson Certified ALS Center. Hi, Marianne.
Hi, everybody. It's nice to see you all. I am the co-moderator along with Cherise Santos. Cherise is also a nurse for the Greater New York chapter of the ALS Association, and she is a patient services coordinator for the chapter for several years as well. So on behalf of the chapter, I'd like to welcome everybody to this important session on palliative care and hospice and end-of-life choices in ALS. We realize that sometimes these decisions are difficult. So if after today's talk, if you have any questions or you would like to speak to any of the chapter staff, we're available for you. Any questions that you have for today's speakers can be typed into the Q&A or chat functions, and we will address them all at the end. So I have the honor to introduce to you today's distinguished speakers, and I'm going to do that in order of appearance for them. So first will be Dr. Caroline Crooms, who is a neuropalliative medicine specialist at Mount Sinai and provides an extra layer of palliative support to the ALS clinic at Mount Sinai. Dr. Crooms also conducts research on how palliative care improves quality of life for persons with serious neurological conditions. Then Dr. Robin Plumer, has more than 35 years experience as an ER doctor in New Jersey and New Zealand. Since 2017, she has been a full-time hospice physician and is assistant medical director at Seasons Hospice in Edison, New Jersey. She is the founder and president of Compassionate Endings NJ, where she and Ms. Stanton have a very personalized practice in medical aid in dying. And Ms. Elizabeth Stanton is the executive vice president of Compassionate Endings NJ. Ms. Stanton has been a critical care nurse, an emergency room nurse, a travel nurse, and professor of nursing and allied health. She works closely with medical aid in dying patients in New Jersey, along with Dr. Plumer. So without further ado, I'll turn it over to you, Dr. Crooms. Thank you.
Great, thank you. Let me just get my screen pulled up here. Go back a slide. Okay, can you all see my screen? Okay, I'll take that as a yes. So thanks so much. Good afternoon. I'm really pleased to be invited to speak to you all today about palliative care and ALS. So first of all, I don't have any financial disclosures. And I'd like to start off by talking about what palliative care really is, since many people may not be familiar with it or might have heard differing things. So the actual definition, as written on the slide here, is fairly broad, and it comes from the Center to Advance Palliative Care. Palliative care is specialized medical care for people living with a serious illness, such as ALS. It's focused on providing relief from the symptoms and stress of the illness to improve quality of life for patients and families. It's interdisciplinary care based on the needs of the patient and is appropriate in any age and any stage in a serious illness. I'll go into some more detail about what that means, but the way I think of it is that where much of medicine is based around treating disease, which is obviously incredibly important, palliative care deals with the adverse consequences of the disease and takes sort of a holistic view of the needs of individual patients and families, ranging from symptoms to spiritual support to advanced care planning. Your palliative care team, really won't manage your riluzole, but they will treat your pain and talk about coping strategies, for example. And there's good reason to involve palliative care in your treatment plan. There have been many clinical trials at this point showing that palliative care is beneficial to patients and families. The original research was in cancer, but more and more we're seeing this in other conditions, including ALS. So using the trials in cancer as an example, patients with cancer receive either oncology care alone or oncology care plus palliative care from early after diagnosis. And the patients in these trials who received both palliative care and oncology care reported better quality of life, greater satisfaction with their care, and greater likelihood that they received the type of care that they wanted. So doctors don't always ask about that last piece, but it's really important to many, if not most patients, and spending time discussing goals and preferences for care is a big part of what palliative care teams do. So that's going to be one of the focuses of my talk. But before I get into that, let's talk more about what palliative care looks like in practice. I think the first thing to emphasize is that palliative care should really be a part of your team. In our ALS clinic, I'm seeing patients on the same clinic days as the ALS neurologist and the rest of the clinicians. So social work, physical therapy, occupational therapy, respiratory therapy, and we all discuss the care plan together at the end of the day. And that's really how palliative care works, is to work in tandem with your other clinicians. I think sometimes people fear that palliative care means giving up the rest of their services, and that's really not the case. It's meant to be, as we've seen a couple of times, this extra layer of support. So in terms of the nuts and bolts of how palliative care works, it really should be a group effort. So as I mentioned, it's an interdisciplinary specialty, not limited to physicians. You'll also have nurse practitioners and nurses, social workers and spiritual care providers or chaplains, really just a kind of holistic team approach to the different needs of patients with serious illness. And the core areas addressed by palliative care teams are symptom management, which might include pain, anxiety, depression, constipation, sort of any number of things that might bother somebody, psychosocial and spiritual support, and then communication about medical decision making and advanced care planning, which I'll talk about some more. And then sometimes end of life care, although end of life care really more appropriately falls under the separate umbrella of hospice, which you'll hear about later from our other speakers. However, sometimes patients do end up receiving end of life care from palliative care teams. And in terms of where palliative care is delivered, palliative care teams most often see patients in hospitals. The vast majority of hospitals now have an inpatient palliative care team, but it can also be in outpatient clinics, including having a provider embedded in ALS clinic the way that I am, but sometimes in separate standalone clinics. I think one thing to note is that the inpatient palliative care teams are almost universally going to be interdisciplinary, as I mentioned. In the outpatient setting, I think a lot of clinics are still sort of building that up, and it may be exclusively a physician or a nurse practitioner that people see. So when should you seek palliative care? The short answer is early. And I'm showing here the bow tie model of palliative care integration, which you can see that the blue triangle on the left represents the type of disease management that the ALS neurologist might do, really trying to manage the disease and treat the underlying ALS. And then the pink triangle represents palliative care, which very, sort of explicitly does not manage the disease, but manages some of the other issues like the symptoms and stressors. So as you can see, there's sort of a role for palliative care from the get-go, but it might not be the focus because you might not have as many symptoms, or you're really kind of dedicating a lot of time to figuring out the disease management strategy. But the role for palliative care increases as the disease progresses and can change as well. And as I mentioned before, clinical trials have showed that the benefits of palliative care are really maximized when it's started early. So people are generally encouraged to seek palliative care early when possible. So you might wonder what palliative care has to offer early in the disease course. And this graph here is from one of those clinical trials that I mentioned in oncology, where they looked back at the palliative care notes to see what kinds of issues were addressed in each visit. You can see on the x-axis, we have different points moving forward in time. So from the first clinic visit to the last clinic visit. And then on the y-axis, you're looking at the percentage of patients whose, first, second, third, et cetera, visits addressed a particular issue. And so we're just looking at the different issues. So as you can see, very few of the visits addressed advanced care planning or treatment decisions at the early visits, which were more focused on getting to know the patient and their family, getting to talk about symptoms, coping with a new diagnosis of serious illness, that in this case was cancer, and only later in the disease course, as that relationship had been established and things were changing with the disease, that they began to address advanced care planning and treatment decisions. So for those who might be worried that palliative care means talking about the end of life, it's really not the case. Now, that being said, palliative care clinicians do have expertise in communication about advanced care planning and treatment decisions. So advanced care planning is a conversation about your goals, values, and preferences for medical care, because we know that not everybody wants the same treatments. Some people wish to pursue all available treatments and clinical trials for their disease. They want to have any treatment that might prolong their life. Some wish to avoid certain types of treatment, so they might have some limitations that they would place on that sort of all available treatment plan. And then still others really wish to minimize medical interventions and focus exclusively on comfort. And as your team, anybody on your team, whether it's primary care, neurology, other providers, or palliative care, it's really our job to support any decision that you make regarding your care. And these advanced care planning conversations provide an opportunity to make sure that you receive the necessary information about your options in a way that's acceptable to you. So understanding how you like to receive information, when you like to receive information, who you want involved in hearing about it. Also to identify the person or people who should speak for you in a crisis. And then to share what is most important to you now and at the end of life. So advanced care planning has been studied as well and has a number of benefits, including improved communication with your team and your loved ones. It can be really hard to have these conversations, and people often find it most helpful to have it in a supported environment with people who have communication expertise. And it also helps your team to provide better care, because that way, we're really understanding what's important to you and can tailor recommendations about treatment to what's important to you. And then the other thing about advanced care planning, another reason to engage in it, is that doing it ahead of time can make decisions much easier if a crisis comes, because then we're really able to honor your personal wishes, and everybody can feel more confident that we're providing care as you would request. So there are a few core decisions that are usually relevant to advanced care planning and ALS specifically. And those include ALS medications, whether to enroll in a clinical trial, placement of feeding tubes or a tracheostomy, hospice enrollment, as you're going to hear more about, and then code status, by which we mean cardiac resuscitation or CPR, and mechanical ventilation or a breathing machine in the event that someone has a cardiac arrest or is not able to breathe on their own. And I'm specifically speaking there about a tracheostomy or intubation, so not the non-invasive ventilation that I'm sure folks are familiar with. So for each of these decisions, advanced care planning, and really any conversation about making one of those decisions, should cover what the treatment is, what the expected benefits are for you personally. So, we can say, oh, the benefits on a population level are this and that, but it can be different in a different person's clinical scenario, what we really expect. And so it's helpful to know what benefits are expected for you. And then similarly, what are the risks or drawbacks for you personally? And finally, how would the treatment contribute to meeting your goals? So just as an example, for someone whose goal is to be as social outside of the home as possible, the intensive treatment regimen with Radicava, which is an IV infusion that you do every day for 10 days, might not be ideal. And so really getting to understand what it means to choose or not choose something can be really helpful. And then finally, advanced care planning may also cover advanced directives, which you may have heard of. And these are legal documents that formally record your wishes. They include durable power of attorney for healthcare or healthcare proxy. Those are the same thing. Living wills, and then medical or physician orders for life-sustaining treatment. And the difference between the MOST and the PULSE that you see there is just a state by state what it's called. So here's an example of a healthcare proxy form. And I really encourage everyone to fill out a healthcare proxy form or durable power of attorney for healthcare, including people who do not have a serious illness. It designates the person or people who can speak for you and make decisions if you're not able to express your wishes. And the reason that I feel so strongly about people filling out a healthcare proxy form is that the legal next of kin, so the person that the state says would make decisions for you when you weren't able to, that person may not be the same person that you would choose, or sometimes legally it's multiple people. And that can make it much more difficult. So you really want to be able to say, who's the person who knows me the best, who could speak with my voice and make the same decisions for me that I would make. And then it also allows you to have those conversations with that person and make sure that they know what you would say. So here's an example of a living will. There are many different advanced care planning tools available to people to fill out on their own outside of a conversation with a medical provider. But this is just one that we commonly use. So the 5 wishes covers many different types of treatment and care preferences. So in addition to assigning a healthcare proxy or healthcare agent, it also addresses things like the types of care that you would want to receive, whether it's now or as the disease progresses. It covers things like how you would want to be bathed, where you would want to be physically, whether it's at home or if you'd be okay going to the hospital, sort of a broad array. And so it really allows for a little bit more nuance in your advanced directive and can be very helpful. And it's been described as the living will with a heart and soul. And I think people sort of connect with it fairly well at times. So, and then finally, the medical orders for life-sustaining treatment. And again, all the forms that I'm showing are for New York State, but every state does have them. So I really think of the MOST or the POST form as being for people who want to be very explicit about certain types of care, such as resuscitation and mechanical ventilation. I think most useful for people who feel very strongly that they do not want a treatment, because the default is always to proceed with emergency life-sustaining treatment like CPR. So these orders, and this is just the top half of the first page, it's signed by a doctor or a nurse practitioner, or physician's assistant, I think also can sign them. And it carries the same weight as an order in the hospital. So if, for example, you call 911 from home, the EMTs will follow what is on the form. So the default, regardless of whether the healthcare proxy is present, is to proceed with, for example, CPR. And the healthcare proxy cannot ask them not to do that, even if they are the legal proxy. But if you have this signed MOST form or POST form, then the EMTs will follow what's on there. So I think it can be helpful, again, for people who feel strongly about not receiving a particular thing. And here's just the second page. Usually they would either both be pink or both be white. And you can see that it addresses or other decisions, not just about cardiac resuscitation and mechanical ventilation, but also about things like feeding tubes and hospitalization and different types of care. And the last thing I would say about advanced directives is that it's really helpful to actually send them to your providers, to your doctors, or whoever is caring for you, and to share them with your closest care partners, because very often people fill them out. They've been clear about their wishes, but nobody has access to them, and so we don't know if it's not shared. So that was a lot of information in a short period of time. I hope I didn't overwhelm you completely. But I've got a few sort of take-home points here, things to remember. So palliative care is a team effort that provides extra support with physical and psychological symptom management, coping, psychosocial and spiritual support, and decision-making aligned with your goals. It's most beneficial when it happens early, and the kind of services that palliative care provides will evolve over the disease course with you and with what is needed for you. And finally, supportive communication and decision making can really help to empower you and your care partners to take charge of your treatment plans. And with that, I just want to acknowledge our wonderful ALS clinic team at Mount Sinai, and then I will hand the reins over to the other speakers. Thanks so much.
Okay, hello everybody. So my name is Dr. Plumer, as we said, and I'm a former ED doctor who now does palliative care and hospice. And I think what people don't always realize is that hospice really is along a continuum from palliative care. And what I mean by that is you can get palliative care from the very beginning of a diagnosis. And like Caroline pointed out, the amount of palliative care may increase, or the engagement with palliative care may increase as the disease progresses. Now, hospice, particularly in the United States, has some very specific requirements. Number one, the person has to have a terminal diagnosis, but the other part is they have to have an expected prognosis of 6 months. And this is one of the big things that distinguishes hospice from palliative care, which is why it's more end stage. Now, the fact that there's an expected prognosis does not mean that the person has to die in 6 months. People can certainly be on hospice for a much longer time than that, sometimes even several years. But there has to be an expectation at the beginning that that's the expected prognosis, and it's not a definite kind of a thing. So ALS, from what I've seen, is wonderful in the sense that the care is always a team effort. And I know that those of you who attend a clinic will have seen that, and you've heard about it from Dr. Crooms. But hospice is also a team effort. And the difference, I think, is that it's all focused on the patient at home. So prior to hospice, people have to go to the clinic. Now, I will say that these days with telemedicine, it's become a lot easier to have access into the home. But hospice is quite home-based. And for the most part, the team would come to the patient at home. So that would typically be a nurse and an aide and a social worker and a spiritual support person, and then some other extra team members as well. Like Seasons Hospice, the one that I work for, has a music therapist that visits whatever patients are interested. Some have pet therapy, some have massage therapy, again, all coming to the home. So next slide, please. Thanks. Again, like palliative care, hospice focuses mostly on the symptoms, but even more intensely. This becomes more of the focus, more than treating the specifics of the disease. And these are the symptoms that are typically discussed and are common for ALS patients as well as other people in hospice. Shortness of breath, pain, constipation, nausea, and anxiety. These are the main things that we do focus on. Next slide. Okay. So the thing is, the way that hospice is, again, in this country, is that you have to kind of make the decision to switch over from what they call active treatment or active management of the disease to comfort care. Now, again, palliative care within the clinic system, clinic setting, allows people to have both. They can be getting their medications and they can also be getting some palliative care. By the time you get to hospice, it becomes much more focused on comfort and much less focused on active management. And I just want to say that does not mean that the patient doesn't have access to the people that they've come to know and trust in the clinics, because they do still have contact. But generally, by the time people decide to join hospice, they're not really well enough to go to the clinic anymore. And again, with telemedicine, it expands your options to stay in touch, but certainly phone calls with trusted members of the team can continue. But hospice assumes the primary care of the patient. So symptom relief and comfort is the main thing. However, medications like Riluzole and Radicava are not going to be covered by hospice. And part of that is just the way the hospice benefit has been designed, that it can't really afford to cover medications like that. But there's a lot more emphasis on pain management and shortness of breath and anxiety. So morphine and Ativan are used a little bit more freely. And I do want to point out here that many people are so worried about morphine and think that it's going to suppress breathing. But in the doses that are used for hospice, morphine has never been shown to suppress breathing. Okay, in small doses, it actually relieves pain, relieves anxiety, and most especially, it relieves the sensation of shortness of breath. Okay. However, because of the technical aspects of hospice, by the time someone does decide to come to hospice, they should already have obtained their equipment, like the personalized wheelchairs, the eye gaze machines, and other specific equipment, because hospice cannot supply those. Okay, next slide. So you might say, what about peg feedings or ventilators? Now, if someone has a peg tube already, then that can be continued through hospice. And again, the way the hospice benefit is supplied in this country, which is whether the person is on Medicare, Medicaid, or has private insurance, when they join hospice, most of their care happens through hospice rather than individually charging the insurance. And therefore, the peg tube would be in, and hospice would generally cover the actual feedings. Okay, the feeding solution. All right. BiPAPs and ventilators are now very well accepted as contributing to comfort, and so those also will be covered by hospice. Although your hospice supplier may not always use the exact same equipment. They may have contracts with different companies, so they might have to switch out the equipment. But BiPAPs and ventilators would be continued. Next slide. But there's kind of an understanding that because people are getting toward the end of life, that these are not going to go on forever, all right? And so complications do sometimes often happen with peg tubes, where people have aspiration pneumonia. And what that means is that although the feeding solution goes directly into the stomach, it can reflux or come up through the esophagus, and people can breathe it into their lungs, and it can develop pneumonia, okay? And at some point, people may decide that the burden of feeding exceeds the benefit of feeding. And so there's kind of an idea that this is going to be a time-limited modality. As far as the breathing goes, most of the time that gets continued up until the end of life, because it's pretty hard to take a BiPAP off someone who's BiPAP dependent. But people do use BiPAP to a different degree. Some people use it just a little bit. Some people use it 24 hours a day, and that's fine. One of the other focuses of hospice is to keep people out of the hospital. So if someone were to develop an infection such as pneumonia or urinary infection, it's possible to treat them at home, generally not with intravenous antibiotics, but with oral, or as I said, if someone has a peg tube, the antibiotic can go right through the peg, and certain infections can be treated at home. So all of the focus really is to try to keep the patient at home and bring care to the patient rather than making the patient go to the clinic or hospital. And one of the things I think is amazing about hospice is I think it's the only aspect of American medicine where you have a 24-hour nurse on call that you can call with any problem. get somebody immediately by calling an 800 number. And in fact, the nurse will come to your home at any time of the day. And I don't think that there's anywhere else in American medicine where that happens. Next slide. So people ask, well, how do I die with ALS? People are terrified about that, okay? And there's this worry that there's going to be gasping or choking or inability to get air. But, basically most of the time, death from respiratory failure is a lot more common than that. And I think the key thing is that if you have the medications available to treat those symptoms, the morphine and the Ativan, it's generally a pretty peaceful death. We don't generally see people gasping and suffering. That said, it still is a pretty scary scenario. And in some states, there's also an alternative, which is called medical aid in dying. And although people with ALS can have quite a peaceful death from ALS, some people don't wish to wait till the very end stage. And I'm going to pass this discussion over to my partner, Elizabeth, who's going to talk about medical aid in dying, which I do want to say is not available in New York at this time, but it is in New Jersey.
Oh, sorry, give me 1 second. We're having a little technical difficulty here. 1 second. Here we go. Okay. Hello, everyone. I'm here to discuss medical aid in dying, also known as MAiD. It's a difficult topic to talk about, but it's something that everyone should think about if you're diagnosed with a terminal illness. There are 9 states currently in the United States that have legalized medical aid in dying. Hawaii, the District of Columbia, Montana, Maine, Oregon, Washington, Vermont, California, and the last state to legalize it is New Jersey, and that happened in August of 2019. If in my career, we asked somebody, if you could pick the best way to die, what would it be? And so many people say, I'd like to die in my sleep. You hear, oh, he died in his sleep. And that's essentially what medical aid in dying is. I will tell you what it isn't. It is not suicide. And that's something that people need to understand. In suicide, there is a choice between life and death. In medical aid in dying, it is not about a choice. It's just about the timing. Okay. There are certain requirements that a person has to have in order to qualify for medical aid in dying. First and foremost, this has to be their decision. Nobody can make that decision for you. And that's a very big part of what we do, is make sure that there is never any coercion. So the person must have a 6-month prognosis. And as Dr. Plumer talked about, 6 months is not it's not a fast and hard rule. It's a basic approximation based on the normal trajectory of a disease. It sometimes can be longer, it sometimes can be a little bit shorter. You must be mentally competent. It must be you deciding on it, not your spouse, not your healthcare proxy. That can never happen. The person who chooses medical aid in dying must also be able to self-administer. And what people say is, what does self-administer mean? It cannot be given intravenously through an IV or through a shot. It must be drank. You can drink it. It's a compounded medicine, powders that can be mixed in juice, and the person can drink it. If the person, and I've worked with a few ALS patients that weren't able to swallow. There are alternate methods. One of them is the rectal route. And that just involves a small PEG tube or a tube into the rectum that comes up to about the belly of the patient, the other end. And so long as they can depress a big syringe, whatever part of the body is working, that's considered self-administration. I will say that typically death comes within within 2 hours is our basic number, but time to sleep is usually about 10 to 20 minutes. And once that sedated sleep happens, you know nothing, they know nothing else. There is no pain, there is no consciousness. And the person just basically dies in their sleep. I have attended many deaths, MAiD deaths, and people have found it, that the families have found it very comforting to know that they were able to follow their loved one's wishes and at the same time be there and be present and be able to say what they needed to say, and do that one last thing. To that end, Dr. Plumer and I have started our own medical practice called Compassionate Endings NJ. Now, we only operate in New Jersey. You have to be a New Jersey resident, and you have to be whatever state that medical aid in dying is legal in is where you have to be a resident. Now, to prove residency, either a driver's license, a mortgage, a voter registration card, or some other comparable means of proving residency. To date, we are pretty much the only practice that focuses entirely on medical aid in dying. And we do this so that we can truly give personalized service. We are with you from the beginning to the end. We come to your home, we speak with you, we speak with your family, we find out what you want. We talk about when you want this, and you decide. The person who's doing this is the one who makes that decision. Nobody else can make that decision. And they can say, I want this done, 2 weeks from tomorrow. And we show up in 2 weeks and they say, you know what? I don't think I can do it. Okay. And that's okay. It's absolutely fine. We are there and we will come back when you ask us to. We are the only medical practice that will attend to a patient on their medical aid in dying day. We will be there from the beginning. We can mix the medication for them. We will present it to the patient in whichever way they are able to take it, whether that be through swallowing it or if they can depress the plunger on a rectal tube. And as I said, once again, the rectal tube is very, very small. It's not an uncomfortable process. It's nothing like that. And we stay there, and we will tend to the person's needs. We also are there for the family. We explain to them what's going on. We can tell them when they've finally gone to sleep. And Dr. Plumer will pronounce the person and will also make all the arrangements, fill out the death certificate. We pretty much do everything that we can to make a person's passing as easy and as painless as possible. I know it's very difficult to discuss, but it's something that everybody should think about in their lives if when posed with a terminal illness. I will say that we have worked with many patients with ALS to a point where we've sort of become specialized almost with the ALS patient. We worked with a few different ALS clinics, and they've helped with our education as far as how things progress. And we have found that that we work together. We work together with hospice also, and Dr. Plumer just spoke about hospice. We will work concomitantly with your hospice. It's something that we put out there. It's just another end of life option, and it's something to consider. Is there anything, Dr. Plumer, is there anything you want to add?
I just want to say it's a small percentage of people who choose this option. It's people who really like to have some control, specifically in a disease process that takes away a lot of control. So although it's only something that appeals to a very small number of people, it's just good to know that the option is out there.
And oftentimes it's people make this decision when they realize that suffering has outweighed the joys in life. And only they can come to that decision. And more times than not, they find that their families are very supportive. Sometimes you may have to talk to them, but for the most part, it really, if you had to choose a way, it at least allows everybody to say goodbye. And it at least allows to say that you do really die in your sleep, and that is the truth. There's no pain, there's no consciousness, there's nothing like that. If you have any questions, we will answer any questions if anybody wants to contact us. We have no problem just giving you education on it. It doesn't mean you're signed up with us. Please know that. But what we really want to do is just make sure that people are aware of this option. And we're always happy to answer questions. So
Hey, should we switch over to Q&A?
I think we're good. Yeah.
Thank you so much.
Okay, good. Okay. Okay, is it just you now? All right, there we go. Okay, good.
Charisse, you're muted.
Caroline, you are too.
Sorry, I'm sorry. We do have several questions, and I'm just going to start, and whoever is wants to answer can answer. But I think this is for Dr. Crooms. Does the most have to be the pink color?
No, it doesn't. It can be pink or white. The reason often that it's pink is to make it easier to find for emergency medical services if they come. But many people might feel uncomfortable, having this bright pink sheet with your care preferences on your refrigerator or whatever the case may be. And then white is perfectly fine. It doesn't change the legality of it.
Okay, thank you. The second question is, does palliative care give the patient quicker access to a hospice program?
So that's a good question. I think the answer is a little bit nuanced. So it doesn't affect hospice eligibility. However, people do often enroll in hospice earlier if they have palliative care involvement. And the reason for that really is that there tends to be more of that sort of supported communication and, making sure that people, if they want to be, are aware of their disease progression, and they may be thinking more in having these conversations about what the goals are. It may be that the eligibility is clear to the person with ALS earlier, and so they choose to enroll closer to the beginning of eligibility.
Thank you. The next question is, when do we know that we need palliative or hospice care? I guess that's for anyone.
Anybody?
Caroline, you can go first.
Yeah, so I think with palliative care, it's fairly personal. I mean, I think palliative care can have a lot to offer people from the time of diagnosis. When I personally see people early on in the disease course, we tend to focus on just getting to know each other, talking about coping in a way that there's more time to do so. In your appointment with the visit with the ALS neurologist, there's going to be a lot of talk about medications and medical equipment and the kind of the medical details. Whereas I have more time and bandwidth to talk about the worries that people have and strategies for coping. And we might also talk some about symptoms. And then, later on it might evolve. Other times that can be really helpful to think about palliative care, if you haven't been seeing someone already, would be if there are refractory symptoms, so symptoms you've been trying to get under control and it hasn't really worked. If you're wondering about some of the advanced care planning questions, there's often it's a dedicated space to talk about that. Another time it can be helpful is if there's a lot of family distress about some of these decisions or information sharing. It can be really hard as a person with a serious illness to have to share these decisions with your family or even just to talk about the illness. So if there's a lot of distress among family members, that can also be a good time for palliative care, I would say. And then I think also if there are questions about the decision to enroll in hospice, that's also something that palliative care can help with. So those are, I think, some of the more common scenarios in which, if it's not kind of an automatic part of the care that you receive, that you might seek palliative care. And then I'll let Dr. Plumer talk about hospice.
Yeah, I mean, the way I see it is that palliative care is in parallel with active treatment, right? As while people are going through whatever treatment they're getting from the ALS clinic. And once the focus is toward comfort care and no longer toward what we call aggressive care, and also when the person really needs to be or wants to be home and just focused on symptoms, that's when it's hospice time. But there is the requirement as well that you have to be certified as having an expected prognosis of 6 months or less. And that generally has to do with the rate of progression of symptoms, which varies tremendously in ALS patients. And a lot of it has to do with ability to swallow and breathe. Okay, so that's one of the big things.
Thank you.
Mhm.
Another question is, I've been led to believe that hospice care and the ALS clinic are mutually exclusive. How is this handled by insurance?
So technically, insurance-wise, as I said, whether you have Medicare, Medicaid, or individual insurance, when someone signs on to hospice, hospice kind of assumes all of the care related to the diagnosis. It's a little bit tricky, and the reason I say that is if you are eligible to join hospice with ALS, but you have diabetes on the side, your regular insurance will still cover diabetes separately, but hospice would cover everything to do with ALS. And I think because of the kind of people that work in an ALS clinic, they wouldn't cut anybody off. Okay. They would still be available as far as advice and help for things and areas of expertise. But technically speaking, the medical care for ALS would go through hospice once you join hospice.
And I think it may depend also on the ALS clinic. I think some places may have different policies. I know in our clinic, we do still very commonly, if people choose to still follow up with us after enrolling in hospice, we do that, but there may be exceptions. I don't know.
Right. We only know the New York, New Jersey, Pennsylvania area, and all of those clinics seem more than helpful. I mean, they all have personal relationships with their patients, so they're not going to just drop them if someone decides to go to hospice.
Thank you. And another question is, does hospice quicken the end of a patient?
Such a good question. So hospice philosophy is that we don't make anybody die faster or slower, that we only treat the symptoms, okay? And that's really the core of hospice. And although unfortunately people think of hospice as just dying with hospice, hospice is really all about living to the best, of your ability, living in full and having the best precious time with family and friends. So no, it's not in any way meant to shorten life. It's just meant to treat symptoms, which is how it's different from medical aid in dying, right?
And I think anecdotally, it's not uncommon for patients to to sort of feel better once they've enrolled in hospice, and that kind of translates into the time being better spent and feeling actually better after they've enrolled in hospice.
Right.
Thank you.
Mhm.
Another question is, does my doctor need to refer me for palliative care or hospice, or can I request this independently?
Yeah, so for palliative care, to some extent, it depends. I think for if you are in the hospital, you have the right to ask for a palliative care consult, and so you should be able to ask primary team in the hospital. In terms of an outpatient referral, I think it depends a little bit more on what your system is. So like I, for example, don't need someone to be referred by another physician. If somebody wanted to self-refer who had ALS or go through the ALS Association, I will happily see that person. So it really just depends on if your insurance requires you to have a referral from somebody to see a specialist. But in general, there shouldn't be any problems with access, and palliative care services are covered by insurance.
Yeah, and hospice can be self-initiated, but typically if someone calls and says, I'd like to be considered for hospice, they still have to provide some kind of records. And so essentially in the end, there ends up being a referral from a medical person, but it does not have to be initiated by a doctor or a nurse. The patient themselves or their family member can call and say, I'm interested in hospice, and an evaluation can be done at that time.
Okay, great. Thank you.
Mhm.
Another question is pain management part of these specialties?
Absolutely.
Yes,
That's the primary thing.
definitely. Mhm. I guess the one caveat is that it's really pain related to the serious illness. So sometimes, people will want to see me or other palliative medicine specialists for like their chronic back pain that they had 30 years ago. And that's usually best managed by a chronic pain specialist, but lots and lots of pain management training. And it's a big, huge part of what we do.
Totally agree.
Okay, and I have one more question. How do I choose a hospice, and can I interview a few of them?
Yes, you can interview a few. And there are lots of hospices around. And I think for anyone who's considering a hospice, one thing might be to ask the ALS clinic where you attend if they have experience with some of the hospices. And the other is, yes, to call up and ask questions, essentially interview them and find out what their experience is with ALS patients. Different hospices have some different rules, and some are a little bit more lenient with certain kinds of what they call carve-outs, or a little bit like more expensive treatments. And I mean, I can only speak for Seasons because I work for them, to say that they do have a program where they will sometimes cover specialty items if people have a certain reason that they want them. So some are more flexible than others. Yes.
Thank you.
Mhm.
There's another question that says, why is medical aid in dying not available in New York? Do you think there's political opposition?
So I think that New York is trying really hard actually to get medical aid in dying passed. And there is a group
Yes.
called End of Life New York that is pretty active, in that area. Yes, it's always political. In our, Oregon, Washington, California were the earlier states to institute medical aid in dying. On the East Coast, it's only, I think, Maine and New Jersey currently.
And
that-
Vermont.
And Vermont.
Vermont.
But Maryland, New York, Delaware, I think are all looking into it right now. Oh, and DC has it. So
Yes.
yes, it's political. There's an organization called Compassion and Choices, and they do a lot of work in working with the legislatures and trying to get medical aid and dying statutes passed. So one can
Yeah.
only hope, but End of Life
Yeah.
is quite active. Yeah.
They're one of the biggest propelling forces in
Mhm.
getting medical aid and dying for passed from a legislative standpoint, is Compassion and Choices.
Okay, I think that's the end of the questions, actually.
Hey, so we're efficient. We got done a little earlier, huh?
Yeah, oh, really? Yes, we are.
Yeah.
Any further comments or before we wrap it up?
No, thank you for inviting us to speak today. We're happy to have this opportunity.
Yes, most definitely.
Yeah.
Thank you so much for giving your time and sharing your expertise in this very important area. So we thank you.
You're
Yes,
welcome.
thank you so much.
And I would just say that working in our ALS clinic is one of the most meaningful parts of my job. I really love it. And I think, palliative care is just such a great opportunity to really connect with people and get to see how people, really cope with this. So it's a great experience. I'm happy to be here today.
Thank you.
Thank you again.
Take care, everybody.
Thanks, bye.
Bye.
Bye.